wonderfully summarizing, how you came up with this ASCO guideline, and also some of the gaps in the, with the area that we need research. And you're already doing those kind of research. So congratulations, on those research. So I'd like to invite Dr. Cornea for any question.
Yeah. Well, thank you, Jennifer, for that excellent presentation and overview of the role of exercise and lifestyle during treatment. And I really appreciate you leading the ASCO effort to make these guidelines. This is obviously a major step forward, I think, for the field of exercise and lifestyle to have the top cancer organization in the world, ASCO, endorse particularly exercise. So I really thank you for your efforts on that behalf. And I think this will have a big impact in our field in terms of both helping patients now, but also generate even more research in this area. But I have a few questions, a little bit about the process and how you came up with the guidelines that I'm keen to know about. One of the interesting things I found with the guidelines is it's a bit of a blanket recommendation, all cancer patients on all treatments being recommended exercise. And I wonder if there's any discussion on the committee about where the evidence is particularly strong, and should we be recommending exercise during treatment for brain cancer and pancreatic and liver cancer? So I thought it's a bit of a blanket recommendation. Was there any consideration, say, certain types where the evidence is, or how did you feel comfortable generalizing, say, across these other patient groups where the evidence might be much more limited?
Certainly. So this process actually was about a 3-year process of really reviewing all of the evidence. ASCO has a pretty formal process for the consideration of individual studies and the meta-analyses. And there were some endpoints where we did find that the evidence was more limited, and that was especially regarding the quality of life, anxiety, and depression. But the other malignancies, there were many studies that included patients across different cancers, and we very carefully weighed, were there any groups that were not represented in a sufficient number of studies to be included in the recommendations regarding VO2 max, regarding fatigue. Fatigue in particular has a very, very rich literature that includes many studies that focus on individual malignancies, as well as a number of studies that have focused more broadly across cancer types. And we actually went down to the level of studying how many patients with different kinds of cancer were included in those. So when we did find that there were some outcomes for which the evidence was so much more distributed toward individual cancers, we made that clear. In the guideline, there is, for each of the different the different outcomes, we describe the evidence base, and it actually goes into some detail about the studies that made that up and what cancer types were represented there. For the sake of time, we didn't go into that detail in the talk, but you will see in the guideline that there actually is a dive for each of those outcomes in what the data that made them up and who was represented there.
And I guess related to that question, on the pre-treatment phase, the prehabilitation phase, the recommendation was restricted to a particular cancer type, lung cancer, and a particular treatment, surgery. So reviewing that broader prehabilitation literature, studies looking at exercise interventions prior to colorectal cancer surgery and other surgeries, as well as, and potentially prior to, say, neoadjuvant therapies, the committee came down on the side, we need to make this recommendation much more restricted than saying all cancer patients should engage in pre-treatment exercise prior to any treatments. So just your thoughts on that particular guideline.
Right. So the evidence base looking at pre-operative treatment is much, much, much leaner than the evidence looking at exercise during chemotherapy and radiation. And that's exactly as you say. There were a number of studies specifically focusing on lung cancer that the results were consistently positive, demonstrating benefits. Although the number of studies was not large, the results were quite consistent. And that was why we had decided that we might, the term may recommend reflects the fact that the certainty of the evidence is still fairly low. The studies were heterogeneous, and there were, unlike fatigue, where there were 21 different studies, there were 4 to 6 studies in terms of exercise in the preoperative setting for lung cancer. For colon cancer and other abdominal surgeries, the evidence was not consistent. And so there were studies that were positive, there were studies that were negative, and we were not therefore able to make that recommendation to be more encompassing for the preoperative surgery, because there were few studies and the results were not consistent. And so in that setting, we did not feel comfortable making a recommendation. And, there were individual studies for things like breast cancer and some other malignancies looking at preoperative interventions. Some of them tended to be quite small, so they didn't meet our criteria that the studies had to have at least 25 patients per arm. And so in that setting, we did not feel that evidence was sufficient to make any kind of recommendation. So that's clearly another place where there's a gap.
Yeah, I agree. The prehabilitation area certainly is in much more need of research. The other approach when I think about guidelines as well, Jennifer, is this idea of specific indications for the intervention exercise. So, it could have been that, okay, for fatigue, if your patients are fatigued, exercise should be recommended. They have poor sleep quality, exercise should be recommended. But you sort of went with all cancer patients, sort of regardless of any side effects or symptoms. So it was sort of very much that we think this is good for everybody, and it's not based on any specific indications for exercise. And a couple of questions. One, what led you to that? But two, I'm thinking from an insurance perspective in covering exercise interventions. One of the strengths I like about the ASCO guidelines is I think insurance companies will be much more likely to cover exercise during treatment as a specific indication rather than from the time of diagnosis and the balance of life. They're going to say that's probably too much. But would it have been more likely to cover exercise if you had a given specific indications for it and say, here's when exercise should be recommended to patients during treatment versus all patients should be recommended exercise?
So that's a great question. And when we started the guideline process, we did not have a predetermined way that we were going to shape the guidance. But when you look at the studies, most of them did not enroll individuals by virtue of having a particular side effect. And that is changing now. I think there are more studies that in their eligibility are enrolling people with fatigue or with depression or with anxiety. But the bulk of the data that make up the guideline were based on studies that enrolled individuals that were initiating cancer treatment that did not have a particular toxicity at baseline. And so we weren't really able to make a determination that this is a treatment for fatigue. But what we were able to see is that if you recommend this to people, they're less likely to become fatigued. So a lot of the studies more prevented these types of toxicities from occurring or mitigated them, but didn't necessarily start with a population that was enriched in that particular toxicity.
Yeah, I agree. You're right. Many of these interventions have not targeted specific symptoms, and it's more been looking at the different outcomes that might happen with exercise. So I think that's a fair point. Jennifer, I'm wondering what kind of response you've gotten from ASCO colleagues. I suspect some of the responses have started to come in. Is this going to be, okay, yeah, this is nice. If you can offer it, that's a great thing to do. Or maybe, I'll make a recommendation, but not really be able to provide any support? Or do you think this will start to change practice in the sense of oncologists feeling more obligated to say, we really need to be developing and setting up exercise programs? So I'm just wondering about the potential impact on your colleagues.
Well, we certainly hope that, I think there's the impact on colleagues, but then there's the reality, and you alluded to this earlier, that there are many patients for whom exercise during treatment is out of reach because they can't privately afford the infrastructure needed to do this. And there are patients that you can tell go out and exercise during your treatment and they'll just do it, but there's a lot of people that need support. And we don't really have the infrastructure or the third-party payment. And I know this is different from country to country, but in the United States, there's not support for exercise programs during treatment, and that's a real barrier to people. And so we do hope that this effort, in combination with efforts of other groups, the American College of Sports Medicine, American Cancer Society, that will start to lead to coverage for some of these services, which will make it much easier to implement. In terms of oncologists recommending this, I think we've gotten very, very positive feedback on this guideline. It is interesting, we had, as part of our work through the ASCO Obesity Initiative, we had conducted a series of surveys of oncology providers and oncology patients about, did they get information about exercise, nutrition, and weight management during their treatment? And the provider survey, as one would expect, if you're going to take the time to answer a survey, you believe strongly that people should be exercising. And so something like 89% of people said they talked to their patients about exercise. And that was what led us to reach out to patients about, are you hearing from your providers about exercise? And this was a survey that we launched in March of 2020. So the timing was a little bit of a challenge, but we did get 2,500 people that responded in the United States, looking specifically at, did your providers talk to you about exercise, about your weight, about your diet during treatment? Did they refer you to any kind of program? And what we found was that more than half of the individuals who responded said that, yes, their providers had talked to them about exercise, which I think is really very, very positive and favorable, because these were people that felt strongly about it. It doesn't mean that their providers did. Much lower proportion of individuals reported that their oncologist talked to them about their weight or about diet. But we did not find that many people reported that there was anything beyond just talking about this, that they weren't referred anywhere. And I think that's the piece that we really need to be thinking about and working on. Even if the oncologist mentions exercise, if there's not a place for people to go and do it and get the support they need, I think they're much less likely to be able to achieve that.
My last question, Jennifer, just focusing on the cancer outcomes. You alluded to those and the insufficient evidence, mostly observational studies as well. And I'm just wondering how you think, there's a lot of interest now in exercise as a potential cancer treatment and improving these types of outcomes, how that might influence the guidelines and the response of oncologists to exercise if there's more data related to the cancer outcomes. And then the other observation I'll add is all the studies that you showed there, all the large scale randomized trials, if I'm correct on this, are all in the survivorship setting. They're all a post-treatment setting, rather than looking at the potential for exercise during treatment as kind of synergistic with existing treatments and stuff as well. So just thinking about the cancer outcomes and how that might impact guidelines and response, and whether or not we might want to also look at exercise during these treatments for potential improvements in cancer outcomes.
Yes, I think that is absolutely true. And there are not studies right now, other than the prostate cancer study, which is looking at individuals with advanced disease. So they will be certainly undergoing concurrent. And I think actually you probably know more about that study than I do, because I think you might be involved. But that study is unique amongst the larger scale randomized trials in terms of overlapping with therapy. I do think that it is important to be able to look at cancer outcomes in people getting treatment. The ANICTO studies are all too small to look at cancer-related outcomes. They're powered to look at treatment completion and treatment intensity, but they're generally somewhere between 200 and 300 individuals in those studies. And because there were different malignancies, it won't really be to put them together, I don't think will be very compelling. So I do think that that's another gap to kind of to look at during treatment studies and effect on outcomes. But to answer the other part of your question, I do think it will be very compelling to oncologists if you have data showing that a lifestyle intervention actually reduces the risk of recurrence or improves overall survival. That is the type of evidence that is very compelling, both to oncology providers and to people that make determinations about what gets paid for and what doesn't.
Oh, thank you again, Jennifer, for that fantastic presentation and for leading that effort on ASCO guidelines for exercise and lifestyle during treatment. I was thrilled to see those guidelines. So congratulations on that major effort.
Thank
you so much. I hope you enjoy the rest of the day.
Excellent. Thank you so much, Jennifer. And just one very simple question. In Korea, I think maybe similar with other countries, as you mentioned, exercise is not covered by insurance or third party payment. Yet nutrition counseling is covered by insurance and third party payment. So, but then your recommendation is actually kind of opposite. Something that we believe was good and beneficial. There's not enough evidence. But then for exercise, something that is not covered by insurance, we see a lot of evidence on that. So any reaction from the nutritional researchers community on what the recommendation you gave?
Well, I do think it's important to just note that we did not cover malnutrition, cachexia, and a lot of the nutrition consults that are placed in cancer patients really deal with feeding issues, the need for parenteral nutrition. So we did not cover any of that in the guideline, and that is often what is covered for patients with cancer. We did have a very vigorous debate with our nutrition colleagues about the nutrition recommendation for this study because or for the guideline, I'm sorry, they did not want this to be interpreted as saying that nutrition doesn't matter. And there was a faction of the guideline panel who really wanted to include just healthy lifestyle recommendations, things that have been demonstrated to be beneficial for general health. I think, though, because of the process that we had endorsed at the beginning of this, that we were looking at randomized trials with specific outcomes, that it ultimately was not consistent with the guideline process to put a recommendation for a dietary change that wasn't supported by that kind of evidence. But we did have a footnote saying that that should not dissuade oncologists from talking about more healthy nutrition in the global sense because of the other health benefits. But it wasn't that good nutrition didn't matter. It just hasn't been studied.
Excellent. I see that in the paper that more research needs to be done and more research funding is needed in that area. So
always important.
Yeah, thank you so much for clear explanation. So I think that would end our talk and then discussion. Thank you, Jennifer, for making time and then give us a wonderful lecture and discussion.
Thank you so much.